So in 1950, a doctor named Ernest Grafenberg published this paper.
Right.
And he described this highly sensitive zone, hidden inside the female anatomy. And today, like over 70 years later, people are paying upwards of $3,000 for a 90-second injection to physically inflate it.
It is honestly wild.
It really is. So,
Yeah.
welcome to the deep dive. You sent us a massive stack of sources on a topic that is highly requested, definitely a bit taboo, and rapidly exploding in the world of cosmetic gynecology.
Yeah.
We are looking at a procedure colloquially known as the G-shot.
Or G-spot amplification.
Right, exactly.
And I have to say, the literature sitting on the table in front of us is incredibly polarized. I mean, on one side of the spectrum, we're looking at promotional literature and pilot studies generated by aesthetic clinics, plastic surgeons, and the American Society of Plastic Surgeons.
Right, the people actually doing it.
Yeah, and they present this narrative of empowerment and quick fixes. But then you flip to the other side of the stack, and we have these stark clinical warnings from major medical institutions.
Like who?
Like the American College of Obstetricians and Gynecologists, so ACOG, and the American Association of Sexuality Educators, Counselors, and Therapists.
Okay, let's unpack this. Our mission today is to cut right through all that marketing jargon. We want to understand the actual mechanics of the G-shot. Like, we are going to look very closely at the physical reality of the procedure.
Because it's a lot more involved than people think.
Oh, absolutely. Specifically, we're focusing on the most burning question you probably have right now, which is, does it hurt? And what kind of anesthesia is actually used to make injecting a needle there even tolerable?
Yeah, that is the big one.
Right. And finally, we will examine the fierce medical debate surrounding its safety, effectiveness, and, the long-term biological consequences.
Well, to even begin discussing the sensory experience or the pain management protocol, we kind of have to isolate the anatomical target first.
Okay, lay it out for us.
So the Grafenberg spot, the G-spot, it isn't actually a distinct, isolated organ. According to the clinical anatomy sources we have here, it's located on the anterior or front wall of the vagina, about 1 to 2 inches, so like 4 to 5 centimeters, inside.
Just right there on the front wall.
Right. And it sits in a very specific neighborhood right next to the urethra and the Skene's glands.
Wait, I want to pause on the Skene's glands for a second, because the sources sometimes refer to them as the female prostate.
Yes, which sounds totally bizarre.
It sounds like a massive anatomical mix-up, but it actually explains the biology of the area. Those glands contain tissue that is biologically homologous to the male prostate gland.
Meaning they develop from the exact same embryonic tissue?
Exactly. Meaning they can even produce similar localized secretions. I mean, it just proves we are dealing with a highly complex vascular network of tissue, not just some random patch of skin.
Oh, for sure. It is a densely packed region of nerve endings and erectile tissue. And the G-shot itself was invented by a gynecologist named Dr. David Matlock. The clinical mechanism is surprisingly straightforward in theory. Basically, a practitioner injects a dermal filler directly into this submucosal space.
And the clinics are using a few different materials to do this, right?
Yeah, they have options.
The most prominent one is cross-linked hyaluronic acid, which is the exact same laboratory-synthesized gel used in facial cosmetics to plump lips or fill in wrinkles, like Juvederm.
Exactly. But they also utilize platelet-rich plasma, or PRP.
Oh, like the vampire facials.
Very similar concept, yeah. For that, a practitioner draws the patient's own blood, spins it in a centrifuge to isolate the platelets and growth factors, and then injects that plasma back into the vaginal wall.
So it's their own tissue.
Right.
Right.
The theoretical goal with PRP is to stimulate local cellular regeneration and increased blood flow, rather than just providing a passive physical cushion like the hyaluronic acid does.
Okay, that makes sense.
And then a third option mentioned in the surgical literature is autologous fat transfer. That's where fat is harvested from the patient's abdomen or thighs via like a mini liposuction, purified and injected.
Which is a whole extra surgical step. But, I mean, regardless of the material, the mechanical objective remains the same. The goal is to magnify the G-spot up to 4 times its normal resting size.
4 times is a lot.
It's a huge expansion.
Yeah.
Think of the nervous system in that specific area like a dense fiber optic cable network buried under the surface. Injecting a filler isn't adding more cables,
Right, it's just moving them.
Exactly. It's physically pushing the existing nerve cables closer to the surface, but creating a pronounced bulge. Like putting a thicker cushion over a hidden button so it's easier to press. The theory is that this bulge becomes significantly easier to access and stimulate through physical friction during intercourse.
What's fascinating here is how they actually map the target before the needle ever
Yeah,
appears.
how do they even find it?
Well, the patient is placed in the standard lithotomy position, feet in stirrups.
Hmm.
And because the G-spot is an area rather than a visible dot, the practitioner performs a physical and visual examination.
Like a standard pelvic exam.
Sort of, but they often rely on the patient's real-time feedback to pinpoint the epicenter of sensation.
Wow. Okay.
Yeah. Once that specific coordinate on the anterior wall is isolated, a special speculum is used to hold the tissue taut and really expose the area for the injection.
Wait, I'm stuck on the physical reality of this. We are talking about injecting a thick, viscous gel into a mucous membrane.
Yeah, very sensitive one.
Right. And hyaluronic acid is hydrophilic, meaning it acts like a sponge, aggressively pulling in surrounding water to expand and plump the tissue. Expanding highly sensitive tissue inside a confined, highly vascular mucosal space inevitably leads to our next problem,
The pain.
the pain. The immediate thought anyone has when visualizing a needle going into the anterior vaginal wall is like, how is this not completely excruciating?
I know, it sounds terrible, but it is actually the single most common concern addressed in the clinical guidelines. Aesthetic practices have developed a very rigorous, multi-layered anesthesia protocol specifically because that tissue is so sensitive.
So they aren't just going in dry.
Oh, absolutely not. A patient never just walks in, lies down, and receives an injection. It begins with a heavy topical phase. Clinics apply a high-strength topical anesthetic, a specialized numbing cream, or sometimes direct ice, right onto the targeted mucosal tissue.
And they actually leave that topical cream on for a full 30 minutes.
They do, yeah.
That feels like a long time for a quick procedure.
It is, but the mucous membrane of the vaginal canal is highly permeable, much more so than external skin, so it absorbs the topical anesthetic very efficiently, but it still takes that half-hour window to fully saturate those superficial nerve endings.
Right.
But that cream alone is not enough to block the pain of a needle expanding the deeper tissue. So step 2 is a local anesthetic injection.
A numbing shot before the filler shot.
Exactly. Practitioners typically introduce 2% lidocaine into the submucosal layer.
And lidocaine works by locally blocking the sodium channels in the nerve cell membranes, which literally physically stops the nerves from transmitting pain signals to the brain.
Precisely.
Because the 30-minute topical cream has already deadened the surface, the initial pinch of that lidocaine needle is significantly blunted.
Right. And once that lidocaine fully bathes the deeper structural tissue, the area is effectively frozen. Only at that point does the practitioner introduce the actual filler, or the PRP, or the fat transfer.
Got it.
And the filler injection itself is remarkably fast. It usually takes only about 90 seconds to deploy the gel and create the expansion.
Which explains how cosmetic clinics can market the procedure as surprisingly painless.
In expert hands, yes.
Because of that dual-layer anesthesia protocol, patients in the chair generally report feeling a sensation of like deep physical pressure or a mild localized stretching as the hyaluronic acid physically displaces the tissue.
Just pressure, not sharp pain.
Right. The sharp acute trauma of a needle entering a highly vascular zone is completely bypassed during the procedure itself.
Yeah, while you're in the chair.
But numbing agents have a half-life. What happens 2 or 3 hours later when the lidocaine wears off and the nervous system comes back online?
That is where the reality sets in. We see a shift from localized numbness to an inflammatory response. I mean, the tissue has just sustained a puncture wound and the sudden introduction of a foreign volume.
The body knows something happened.
Exactly. As the lidocaine metabolizes, the blood vessels dilate. Patients typically experience a localized throbbing, mild soreness, and a sensation of tenderness.
The sources compared it to the dull pelvic ache following a particularly rigorous pap smear.
That's a really good comparison, yeah. But the clinical literature from the providers indicates that heavy prescription pain medication is rarely required. Standard over-the-counter anti-inflammatories are usually sufficient to manage the rebound ache.
Okay, but we also have to talk about the bleeding.
Right, the vascularity.
Because the anterior vaginal wall is incredibly vascular, meaning it is just packed with tiny blood vessels. You cannot introduce a needle there without causing microtrauma.
It's going to bleed.
Patients are usually provided with a sanitary pad or tampon to manage localized spotting for about 4 hours following the appointment.
And this brings up a critical discrepancy between the marketing and the actual medical reality.
Yeah.
Aesthetic clinics heavily promote the G-shot as a lunchtime procedure with zero downtime. They imply a patient can literally get the injection at noon and be back at their desk by 1.
But the aftercare rules tell a completely different story.
Yeah.
Patients are strictly advised to abstain from any sexual activity, and they must avoid pools, jacuzzis, and soaking in bathtubs for a minimum of 5 to 7 days.
Right, which is not zero downtime.
Not at all.
That is a non-negotiable protocol anytime you introduce a puncture wound into a mucous membrane. The mucosal tissue needs roughly a week to fully epithelialize.
Meaning to grow a new layer of protective cells over the injection site.
Yes, because submerging that unhealed puncture wound in pool water or exposing it to physical friction creates a massive risk for a bacterial infection to enter the bloodstream.
And the timeline of the filler itself is another major factor here. Because hyaluronic acid is organic, the body's enzymes naturally break it down and metabolize it over time.
It doesn't last forever.
Exactly. The physical expansion of the G-shot is entirely temporary. It lasts anywhere from 4 to 12 months, depending on the patient's individual metabolism.
It goes away.
It goes away.
Yeah.
To maintain the amplified effect, the patient must undergo repeat injections. And at a cost ranging from $850 to $3,000 per round, we are talking about a significant recurring financial and physical cycle.
Oh, for sure. It's a continuous loop of repeating puncture wounds in the exact same highly sensitive anatomical zone, maybe every 6 months.
Here's where it gets really interesting. If a patient is repeatedly injecting a foreign gel into the same highly vascular network twice a year, logic dictates that the tissue is going to react.
It has to.
The cosmetic clinics present this breezy narrative of a quick, painless physical upgrade, but biology is rarely that accommodating. The body fundamentally recognizes a needle and a synthetic gel as an injury and an invader.
And that underlying biological reality perfectly bridges the gap to the loud alarm bells being rung by traditional medical institutions.
Let's talk about those warnings.
Yeah, when we examine Committee Opinion number 378 from the American College of Obstetricians and Gynecologists, ACOG, which is the premier governing body for women's health in the United States.
Right, they are the gold standard.
Their stance is unequivocal. They state that procedures like G-spot amplification are not medically indicated, period. And they issue a stark warning about the total lack of peer-reviewed long-term safety data.
Now, the clinics counter that by pointing to pilot studies, like the ones conducted by Dr. Matlock himself, which claim an 87% success rate in patients reporting enhanced sexual arousal.
But an internal pilot study reliant on subjective patient questionnaires is galaxies away from a rigorous, double-blind, independent clinical trial.
Oh, absolutely.
Evidence-based medicine demands longitudinal data because complications often take time to manifest. ACOG documents severe potential risks that completely shatter that lunchtime procedure marketing.
What kind of risks are we talking about?
Beyond the immediate risk of infection from the puncture site, they highlight severe structural risks. Things like adhesions, scarring, and altered sensation.
Let's break down how that scar tissue actually forms. When a practitioner injects hyaluronic acid, the immune system detects a micro-injury and the presence of a foreign substance.
It goes on the attack.
Right. It dispatches fibroblasts to the area, which begin laying down collagen to wall off the invader and heal the tissue.
Which is normally a good thing.
Normally, yes. But in a soft, expanding mucosal area, this collagen can harden into stiff, fibrous bands called adhesions.
And those stiff bands of scar tissue restrict the natural movement of the vaginal wall. But worse than that, as the scar tissue contracts over time, it can physically trap and compress the surrounding nerve endings.
Which leads to ACOG's most alarming documented complication, dyspareunia. That is the clinical medical term for painful sexual intercourse. It is the ultimate tragic irony of this entire deep dive.
There really is.
A patient undergoes a highly specialized, expensive procedure specifically to enhance sexual pleasure. And the body's natural inflammatory response to the filler creates scar tissue that permanently traps nerves, making sex actively and chronically painful.
And because the vaginal wall's neuroanatomy is so delicate, a minor adhesion there has vastly different functional consequences than a minor scar from a lip filler on your face.
A bump on your lip is annoying. A trapped nerve in the vaginal wall is life-altering.
Exactly. But beyond the purely physical risks, the sources highlight a profound psychological debate regarding the very premise of the procedure.
This is where ASEC comes in, right?
Yeah.
The American Association of Sexuality Educators, Counselors, and Therapists.
Yes, ASEX. Their literature includes insights from prominent female sexuality researchers like Beverly Whipple, who point out a massive flaw in the mechanical logic of the G-shot. The G-spot is not a distinct anatomical button just waiting to be enlarged. It is a highly complex, diffuse area.
To understand why it's an area, we actually have to look at the internal clitoral structure. The clitoris isn't just the external glands, right?
Oh, not at all.
It possesses internal anatomical legs, or crura, and vestibular bulbs that literally wrap around and engorge the anterior vaginal canal.
They surround the whole area.
Yeah. So when the anterior wall is stimulated, it is often simply providing indirect stimulation to that internal clitoral network.
Which perfectly explains the data point Beverly Whipple highlights. She notes that only about 20% of women consistently achieve orgasm through vaginal stimulation alone.
Only 20%.
Yeah. The vast majority require direct clitoral stimulation. So if 80% of the population relies on a different primary neuroanatomical pathway, injecting a localized filler into the vaginal wall is not going to suddenly rewire their fundamental biology.
You can't just inject a filler and change how your nervous system is wired.
Exactly. And if we connect this to the bigger picture, ASEC argues that marketing the G-shot actually pathologizes normal human variation.
How so?
Well, it suggests to the 80% of women who don't have vaginal orgasms that they are somehow anatomically deficient and require a surgical intervention to be fixed.
Wow. That's a really heavy implication for a cosmetic clinic to be making.
It is. Now, the American Society of Plastic Surgeons, the ASPS, attempts to navigate the middle of this crossfire.
Trying to keep the peace.
Pretty much. Their guidelines acknowledge the preliminary subjective evidence that localized physical magnification can enhance sensory friction for some women who already experience vaginal arousal.
Okay, so it might work for that 20%.
Maybe. But they explicitly warn that for a patient who has never achieved an orgasm, a hyaluronic acid injection is highly unlikely to be the magic biological switch.
Right, total sense.
And they side with ACOG in stating that rigorous, independent scientific studies are desperately needed to prove both efficacy and safety.
So this standoff really reflects a massive growing tension in modern medicine today.
It absolutely does.
We are witnessing a collision between elective aesthetic enhancements, which are entirely driven by intense patient demand, immediate gratification, and, out-of-pocket funding, and traditional medical standards, which are inherently conservative and require years of proven safety data to ensure long-term patient protection.
It's a clash of two totally different medical philosophies.
So what does this all mean for you? If you have been tracking with us through this deep dive, you now know that the G-shot is fundamentally a mechanical intervention.
A physical cushion.
Right. It utilizes a rigorous dual-layer anesthesia protocol, rely on a 30-minute topical saturation followed by an injection of 2% lidocaine to block nerve signals. And that makes the 90-second injection of tissue-expanding filler relatively painless in the moment.
It gets you through the procedure.
Exactly. It creates a temporary physical bulge designed to increase friction. But you also know the biological cost. The requirement for repeated treatments every few months introduces the very real risk of cumulative scarring, trapped nerves, and permanent pain.
Setting up that fierce battleground between cosmetic practitioners selling an upgrade and medical boards demanding proof of safety.
And ASEC researchers really urge people not to be so goal-oriented with intimacy.
That's a huge point.
If we start treating sexual pleasure as a mechanical issue that can be quote-unquote fixed with a $3,000 injection, are we actually empowering individuals? Or are we simply creating a new, expensive medical standard for what a normal sexual experience is supposed to look like?
It definitely raises an important question to leave you with, one that pushes even beyond the debate over temporary gels.
Oh.
As cosmetic biotechnology rapidly advances, we are increasingly viewing the human nervous system as something to be physically optimized.
Like biohacking.
Yeah. Will we eventually see a future where neurological implants like microdevices designed to directly stimulate the clitoral or vaginal nerve pathways become the new frontier for sexual enhancement?
Oh.
Right. Completely bypassing the messy, temporary, and scar-inducing world of physical fillers altogether.
That is a fascinating trajectory to consider. Are we on the verge of abandoning chemical plumbers for actual electronic optimization?
It wouldn't surprise me.
Thank you so much for joining us on this deep dive into the stack. As always, keep questioning the information you encounter, keep digging into the why behind the headlines, and before you seek out a biological upgrade, make sure you thoroughly understand the mechanics under the surface.